Okay, good afternoon, everyone, and welcome to the last MAG educational seminar for 2023. Today we have Dr. Anthony Robinson, Consultant Orthopaedic Surgeon. Dr. Robinson is a general surgeon with a special area of expertise in joint surgery, especially of the knees and shoulders. Dr. Robinson works with MAG and is based in Western Australia. May I ask that you all please remain on mute so that any noise from your workplace or home does not interfere with the quality of the recording. There'll be an opportunity to ask questions at the end of the presentation. And if you need to leave at any stage, you can type your question in the chat and I will read it out for you. You will receive the recording of this session later today or early tomorrow. And of course, you can watch all our seminars whenever you like by accessing YouTube and searching for Medico-Legal Assessments Group. Or if you have a MAG Connect login, selecting seminars from the menu on the left-hand side of the main page. Without further ado, I hand you over to Dr. Robinson.
You're going.
Anyway, over to you. Yes.
So it's my generation that's causing the problems. But, as I said, my name's Dr. Tony Robinson. Briefly, I grew up in Sydney. I went to the University of New South Wales, did my undergraduate work there. And then in 1980, I went over to Perth, and I've been here for the last 40 years. Did my graduate work over here as an orthopaedic registrar, and did some training overseas, and then come back here. I've just recently stopped operating, but I still see orthopaedic patients. So I have that sort of way of still keeping in touch with orthopaedics, and also I attend the usual type of meetings and things as well. So today I'm going to just talk about what I think is the situations where Zoom lends itself to assessing medico-legal cases. And I'm going to go through it joint by joint. And I'm happy to answer questions at the end. But also, I wish to say that it is my opinion. And some people will say, I disagree with that. I can do Zoom for this, or I can't do Zoom for that. So it's just my opinion, and something that's evolved over probably the last 5 or 6 years. So I will start with the shoulder. So when it comes to doing range of movement on Skype, you can do it if you're used to it or experienced when it comes to measuring angles without the use of a goniometer. And what I've done in the past is I've looked at someone's range of movement, say with flexion, which is the arm going up in the air, and worked out where I think it was, and then used a goniometer, which measures angles, and to verify. So I've done that, and I've found it's pretty accurate. And other orthopaedic surgeons say the same things, and of course other specialists would say the same things. So it can be done on Skype, and it's just a matter of just getting the patient with the right angles, say with flexion extension, to have them side on, and with abduction and adduction, have them front on, and with rotation, internal rotation, downwards movement, external rotation, upwards movement. When the arm is up like that, that's external rotation, internal rotation, but you do it from the side, and you fairly accurate measure the range of movement. So I'd say with shoulders, yes. So with elbows, you ultimately end up assessing elbows usually with range of movement. And again, that lends itself to Skype. It's the full extension type range of movement. That's full extension to flexion. And the other range of movement is when you do supination. Sorry, I'm just trying to get it. So that's neutral position, supination. That's that type of movement, and that gives you 80, 90%, and you can measure it from the various angles. And pronation is the other way, like that, going down. But again, you can measure that on Skype, and I think you can do it quite accurately when you've done a number of these examinations. The only exception is if you get ulnar nerve neuritis, where you get, this is your funny bone there, ulnar nerve runs down in that little groove there. And if it is a problem, if it's something that's been injured or been knocked or any other problem, you can't assess it neurologically on Skype because you have to do what's called the Tinel's test, which you tap there. So when it comes to measuring ulnar nerve neuritis, you can't do it on Skype because you have to be there present, tapping the nerve and looking at the fingers neurologically to see if there's any problems with that. So it can't be done. With the wrist, it can be done. It can be done again with range of movement, just measuring the, that's the neutral way there. That's neutral, and then going down, palmar flexion, and then extension. The other movement that you do with hands is to go inwards that way. That's radial deviation. It's sometimes hard to assess, but you can still do it with Skype, and going outwards like that, which is ulnar deviation. And you can usually test that. So you can probably test it doing that way and that way, just looking at it. The only thing you can't do with wrists is you can't do carpal tunnel. And carpal tunnel is when the nerve there is compressed in the canal. And to test for carpal tunnel, you can't do it through Skype because you have to, again, tap the nerve and see if it causes numbness in the relevant fingers. And also you have to do the Funnings test. Funnings test is when you bend the wrist down for 30 seconds and you see if there's any numbness in the relevant fingers. So you can't do that. The other area going down the upper limb is the fingers. And with the fingers, if there's an amputation, say if there's an amputation of the thumb there, it's very straightforward. But when it comes to measuring sensation in the fingers that have been injured or range of movement, it's pretty hard doing it with when you've got the patient in your consulting room. And it's very hard to do it with Skype. So in summary, I think shoulders you can do with Zoom, elbows you can, wrists you usually can, and fingers I'd say usually no. So I'm just going to go down to the lower limb and looking at hips. Now, when it comes to injured hips due to work-related injuries, it often boils down to range of movement. That's what I've found. And you cannot do range of movement with Zoom in my hands. You cannot. So what happens when it comes to the hip? When you do range of movement of the hip, you have to stabilise the pelvis. You can look at it and do flexion, but it's very hard to do fixed flexion deformities because you have to have your hand under the lumbar spine, and you've got to make sure the spine is not being arched in order to get full extension of the hip joint. And similarly, when you do other range of movement like abduction, away movement, adduction, movement towards the midline, and rotation inwards or outwards, you need to stabilise the pelvis. You need to have them on your examination table and put your hand over the pelvis and make sure that's not rotating, which give you a false reading when it comes to range of movement. So getting down to the knee, and the knee is one of those things that really, it can be a lot of problems with knees, can be, could be soft tissue, could be bony and things. But the way I find that I end up assessing knees from the point of view of whole person impairment is for muscle wasting. It's pretty simple to do, and I measure it in a certain way, and I get compare it with the other side. So as I said, with knees, there can be various causes of knee problems, but I find in about 80% of times, it's measurement of the thigh muscle that'll give me a whole person impairment. And you can't do that on Skype. So I say no to knees. And when you get down to ankles, I think ankles, when it comes to injuries around there, I measure range of movement And again, Skype can lend itself to such an examination and give you a pretty good result from the point of view, or very good result from the point of view of assessing whole person impairment. The only exception is hindfoot range of movement. They can be hard to visualise on Skype, but if it's just ankle, you can. So in summary, when it comes to the lower limb, I say hips no, knees no, but ankles yes, when it comes to assessment through Skype. Now, the other areas, which I'll just mention, are the spine, the neck and the back. And if you look at the IME guidelines, then you can look at them and you realise that a lot of it is on the history, and matter of fact, all of it is on the history. So to be able to assess whole person impairment, sure, it'd be nice to be able to put your hands on the back and check. So when it comes to backs and necks, you can assess them. Because when you look at, say, category 2, which is the most common situation, it's the category 2 involves, which is table 15.3, it involves getting a history of specific injury and then having a history of the pain going down the leg or some numbness in either leg or the upper limb. And then you can, that's 5%. And then you look at the extra problems that the patients have, say with recreational activity, add 1%. With the problems with household chores, you add 2%. And of course, with problems with personal hygiene, it's 3%. So backs do. The only trouble is it'd be nice to be able to do a neurological examination sometimes, if you think there is a radiculopathy. But from the point of view of the AMA guidelines, backs and necks do. So in summary, upper limb, yes, I'd say overall. Backs and necks, yes, but lower limbs, probably no. So this is my opinion when it comes to using Skype. And this is what I've found over the years that works for me and mightn't work for other people. But it does lend itself for someone like myself being interstate. I've got registered. So I have registration from the point of view of New South Wales and Victoria. So Skype can be used for myself in these situations. And it does save the patient a lot of time. It saves a lot of money, and it's very convenient for everyone. And when you get these situations with Skype, you can do them that day, and within 7 days, 5 days, working days, you can have the report on your desk. So it does lend itself Skype, and it's very efficient, and I believe in a lot of cases, in most cases, it is very accurate. So I wish to thank everyone for listening to this presentation. I'm so sorry about the technical problems. I'm just a dumb 70-year-old person who needs a lot of guidance when it comes to computers. And thank you so much for putting up with the technical problems and for listening.
Excellent. Thank you so much, Dr. Robinson.
All right.
You did amazing. We got through that. Dr. Robinson, I just had one question.
Oh, sure.
One of the lawyers asked before, are joint replacements lifelong, or do they need to be replaced after a certain period?
Yeah, they aren't lifelong. Like, for example, for knees, they are lasting for about, so no. So they don't last forever. And that's the reason why a lot of surgeons like myself, when we used to do joint replacements, we didn't like doing them under the age of 60. Because we knew that when it came to hips and knees, they'll only last for about 17, perhaps 20 years on an average. And then if you do it 50, you're looking at doing it 70. And then the second one probably only lasts for half as long. So it's 78, that sort of thing. So it's much better to get them to wait till they're over 60. And technically, it's not as hard. It's it's just as hard to do as it is with someone who's had the problem for for 20 years as it has for 5 years. But the thing with it is that it's the patient who puts up with the pain, so it's their decision, and sometimes they can put up with a lot of pain, and sometimes they want to have it done sooner than earlier.
Excellent. Thank you so much for that, Dr. Robinson.
Sure.
I think that's a wrap up for today.
Okay.
Thank you so much
Thank
for
you
your
so much,
patience in
Tina.
getting
Oh,
through
no,
that
thank you
seminar.
for your patience.
Yeah, thank you for your time, Dr. Robinson. Have a great day.
Same to you. Thanks.
Bye-bye.
Bye-bye.